Pathology and GI surgery. I welcome you all to today's CPC. Today we have Professor Rajesh Gupta with us as the clinical discussor. Sir is head of Department of Surgical Gastroenterology at PGI Chandigarh. He has a special interest in pancreatic diseases, and I think we all know him very well. So I will. It's a pleasure for me to welcome him, and he'll start with the clinical part.
Thank you, madam. It's indeed a privilege and an honor to present CPC here. And I hope I'm somewhere close to the audience. So, coming to the case history, this is a 25-year-old female student, resident of Uttarakhand with no comorbidities and no family history of malignancy, was evaluated for pain abdomen of 6 months duration, mild to moderate in intensity, with occasional episode of severe pain. This was associated with intermittent bilious vomiting, and there was no history of jaundice, hematemesis, or symptoms related to bowel bladder dysfunction, as well as there was no history of loss of weight or loss of appetite. This patient was worked up in Dehradun when she first presented there. They did an ultrasound, and ultrasound showed a hypoechoic area of 3.2 into 4 centimeter in the uncinate process of the pancreas with adjacent mesenteric stranding and suspected short segment thrombus. CT was done 2 days later, which showed again non-enhancing area in uncinate process, almost same size, with again similar findings of mesenteric stranding and large peripancreatic lymph nodes with significant SMV stenosis. And they thought it is an extension of acute inflammation secondary to acute pancreatitis. And they gave it as a CTSI score of 4/10. This patient was treated initially for 4 days conservatively and then discharged. 2 months later, she again had another bout of severe pain for which she underwent CT scan. The CT scan again showed 4 into 4.1 centimeter size of the mass in the head of pancreas with peripancreatic fat stranding and thickening of the wall of D2, D3 with mild ascites. Endoscopic ultrasound done at that time showed 3.7 into 2.7 centimeter hypoechoic area in uncinate process of pancreas with capsule, and they thought probably they are dealing with a cyst. CBD on EUS was 7 millimeter and main pancreatic duct was 3 millimeter, which is borderline. Important is that they found few gallbladder calculi there. They also did EUS FNB, which was inconclusive. So they at that time thought, because of the findings on CT, EUS and ultrasound, that patient probably has a biliary pancreatitis, and patient underwent cholecystectomy at that place. So there were the specimen of this cholecystectomy showed multiple calculi, and on intraoperative finding they found bulky head and body of the pancreas, and histology was chronic pancreatitis. However, in August 22, this patient developed jaundice now. This jaundice was progressive, and now it was associated with vomiting and loss of appetite. So, August, that means 8 months after the first attack of pain, when she presented to hospital, this ultrasound showed further increase in the size of this mass, which is now 6.6 into 5 centimeter with internal vascularity in the head of the uncinate process of the pancreas. And now MPD had dilated from 3 to 5 millimeter. MRI showed which was done almost a month later, further increase in the size, which was 9 into 7 into 6 centimeter, and it showed this mass with necrosis and cystic changes. And also important to note here, the double duct sign was positive. But there was no lymph node distant metastasis in this MRI, which was noted. Endoscopic ultrasound was also performed at that time, probably because of these findings, and they found that the mass was again 7 into 5.4 centimeter in the head of the pancreas near splenoportal confluence, SMA was seen coursing through the mass with maintained fat planes. MPD and CBD were not dilated, and there was, importantly, no retroperitoneal lymph nodes which were noted despite this size. At that time, patient underwent side-wing endoscopy, which showed a bulky ampulla with a large ulcer. They tried doing ERCP stenting, but probably because of the defaced ampulla, it was not possible. Ultrasound-guided FNAC of the pancreatic lesion was performed. Biopsy from the pancreatic lesion was also done. Probably that was not conclusive. And subsequently, patient underwent left PTBD with internalization on 29 September. So these are some of the representative images which was sent to me. So this is MRI which was done on 12th of September that was available to us. This shows a large mass here with areas of cystic degeneration on T2 weighted image. Also, there is a lesion in the segment 6 of the liver which shows there is predominantly fluid. This is a cyst, but there are some solid component or maybe cystic there or septa there. Then here in this, we find on this T2 image that the main pancreatic duct is dilated and there is sudden cutoff in the head of this pancreas in the middle of the lesion, and there is no duct traversing sign. The contrast MRI showed that the vessels were encased. This is SMA, which is narrowed and encased more than 180 degree. And here we see, though it is, equivocal, but there is some enhancement in the periphery of this tumor. And rest of the tumor is actually hypoattenuating. These are again contrast enhanced MRI images which show cyst in the segment probably 4 of this liver. So there were actually more than one cyst in the liver. And as I shown you earlier, this is another cyst with some solid component. And here we also see the SMV is getting encased. And this tumor is also encasing SMV. These are formatted images showing the cyst again. And then the SMV which is stretched and also encased. The tumor is shown in the entire extent here in the head of the pancreas. So this patient after the pancreatic biopsy underwent CT scan, and CT scan showed 6 into 7 centimeter mildly avid lesion in the head, neck and uncinate process with areas of necrosis which were extending into porta-hepatis. This I will show in the next picture. With these findings, this mass was actually encasing portal vein and was abutting celiac axis as well as SMA. This patient received 4 units of packed RBCs and then underwent SEMS placement to relieve jaundice. In view of this locally advanced unresectable disease, she was planned for neoadjuvant chemotherapy. This patient received 4 cycles of chemotherapy from 25th October to 27th December. Then PET CT scan was done on 29th of December, which showed a regression in the size of the head mass in the head of the pancreas. However, the contact of the superior mesenteric vein was still more than 180 degree, and the liver lesions were actually metabolic inactive now. There is no mention of metabolic activity in the liver even in the previous CT scan. I think considering the response, the patient received another 8 cycles of neoadjuvant chemotherapy. And then subsequently in May 23, which means almost 7 to 8 months after the start of the chemotherapy, the CT showed a lesion which was markedly reduced now 3 to 4 centimeter. There was reduced FDG avidity. However, it was at this time only abutting and partially attenuating the splenoportal confluence. She received another 6 cycles after that. So in total, she received almost 18 cycles of neoadjuvant chemoradiotherapy, and that's important to note. PET-CT at that time showed a lesion which is 1.9 to 2.5 centimeter in the head and uncinate process, and soft tissue was seen around SMV, and there was no FDG uptake in the images provided. So this is a CT scan which was done after the stent was placed and probably before the neoadjuvant treatment was given, and this shows the vessels are almost encased and the tumor is infiltrating into the mesentery. And again, this cystic lesion is seen in the S6, and probably this lesion also shows some hyperdensity in the surrounding area. So this is a PET-CT which was done 3 months later. This is after the 4 cycles of chemotherapy. We see the vessels have started increasing in size now. The tumor has probably started shrinking away from these vessels. However, they are still encased more than 180-degree contact. The lesion in the liver are still seen. However, important to see a nodule here in the mesentery, in the just below the duodenum. And these essentially show the same, that the duodenum is, which was touched in the previous images, actually is now getting filled up due to the shrinkage of this tumor. This is a PET-CT which was done initially, and that showed an avid uptake in the head of the pancreas. And this is post-NACT PET-CT. These are the CT images of the PET-CT, and this shows the vessels are almost free, though you still see some stranding around the vessels here, but the lumen and this, you can see soft tissue around these now. And PET-CT does not show any uptake in an area which was initially showing intense uptake. With these findings and significant regression in the size, this patient was planned for surgery. And when she was prepared for surgery, she was ECOG 1, did not have pallor, icterus, and there was no systemic lymphadenopathy or pedal edema. Abdominal examination revealed that the port sites of laparoscopic cholecystectomy were healthy, and there was no mass which was palpable per abdomen. The preoperative hematological and routine investigations were essentially normal. TLC are little on the lower side with platelet, probably because of the extensive neoadjuvant protocol which she has received. Creatinine is almost normal, bilirubin is preserved. However, liver enzymes are raised. Albumin is normal. ALP is less than 3 times. Tumor markers, both CA and CA99 in the preoperative period were normal. On 9 September 23, and this is, if we look at the timeline, this patient presented in January 22 to the hospital. And actually, if we look at that time, she had a history of pain 6 months earlier to that. If you add that, so it becomes almost 27 or 28 months after the onset of the first attack of pain in June 21. So this patient undergoes now, reaches a stage where she undergoes Whipple's pen catecholeudenectomy with feeding jejunostomy. Intraoperatively, the liver was cholestatic with a 5 into 4 centimeter cyst in segment 6. Rightfully, the cyst was aspirated, and the clear fluid which was aspirated was sent for cytological examination. Duodenum was densely adherent to gallbladder fossa. Dense fibrosis was found around the peritoneal area, and these are all because of the effect of the chemotherapy on the initial tumor. There were important large common hepatic artery lymph nodes, and accessory right hepatic and left hepatic artery were present. The metallic stent was there. Pancreas was firm. Intraoperatively, the MPD was 4 millimeter and CBD was 1.5 centimeter, probably because of the stent. This patient had uneventful recovery till day 4, when she had respiratory complication and she had to be put on a ventilator, from which she was successfully weaned off, and she was recovered on post-op day 17, post-op day 24 from the hospital. The patient received adjuvant treatment after surgery, and currently patient is under follow-up and with no evidence of recurrence till now. So with this, if we look at the salient point, this is a little long history. So we have a young female who has a malignancy in the uncinate process of the head of pancreas. However, this young female has no comorbidity and no family history. The presentation is of pain abdomen, which is 6 months, but importantly, at that time, there is no history of loss of weight or appetite. She has hypoechoic area 3 into 2 into 4 centimeter in the uncinate process with mesenteric standing, and this is along with the CT finding, which probably suggests that this patient probably has features of acute pancreatitis in the initial phase of this disease. CT in March shows 4 into 4 centimeter lesion in the hypodense lesion in the head of pancreas, again with peripancreatic fan standing, essentially the same findings. And US, which was done, shows probably a cystic lesion with a normal or borderline dilated MPD and CBD 7 millimeter with gallbladder calculi. The story changes 8 months after the first presentation to hospital when she developed jaundice, and now she has loss of weight and loss of appetite. And then there is progressively increase in the size of the tumor borne out by the USG, MRI and US findings. Important to know that SMA was seen coursing through the mass, however the fat planes were maintained. At that time, she undergoes PET scan, and that shows FDG avid lesion, which we had seen. And ultrasound FNAC was done, but then biopsy was, percutaneous ultrasound biopsy was performed. And this patient subsequently received 18 cycles of chemoradiotherapy. And while she was on neoadjuvant chemotherapy, the serial CT scans showed there was a regression in the size of the tumor. And she underwent Whipple's procedure, followed by adjuvant treatment and no recurrence. So coming to the discussion for this patient, if we look at the pancreatic tumors in the young or in the children as well, the most common is serous cyst adenoma, followed by mucinous cyst neoplasm, then solid pseudopapillary epithelial neoplasm or SPEN, NET, pancreatoblastoma. These are not necessarily in the order of frequency, but they are completing the list. Ductal adenocarcinoma, acinar cell carcinoma, and then inflammatory AIIMS, Kaposi, leukemia. So, I'm not considering the benign tumors here, and I'm focusing on I've put a focus here, which I'm going to discuss because I think probability of diagnosis lies here. So if we look at solid pseudopapillary epithelial neoplasm or SPEN, this is a right setting. A young female who's 25-year-old female presents with a large mass with no jaundice, no loss of appetite or no loss of weight. First diagnosis at that stage would be a SPEN. Especially the tumor markers were normal, and MRI and CCT, which shows some enhancement, as I show on MRI, in the peripheral solid component with central cystic degeneration, which is probably a marker of any large tumor which can undergo cystic degeneration. This tumor also showed mild FDG avidity. However, important thing is that there was no gallium DOTA in this patient done, and also the dilated PD was not accompanied by atrophic pancreas. Other thing which is important in this database is that patient showed good response to neoadjuvant chemotherapy. So if we compare these database with this SPEN, which is a rare tumor seen in 1 to 2% of all pancreatic neoplasms, as I said, this is a setting for this SPEN. Tumor can grow up to the size of 8 to 10 centimeter, as we have seen in this patient, and is generally well demarcated mass with variable solid and cystic appearances, as we had seen in this patient also. There can be enhancing solid areas, mostly peripheral, as we had seen in the MRI and CT of this patient. and cystic liver metastases in SPEN are known. But important to note that SPEN is generally considered a benign disease. It has an indolent course, and annual increase in size is only few millimeters. And if we look at the tumor doubling time, it is 764 days. And in our patient, when we saw the patient from 3 centimeter to 9 centimeter within 9 months, so it's unlikely to be solid pseudopapillary epithelial neoplasm. However, there is a variant which is seen in 10 to 15% of SPEN, which is a malignant SPEN. Still, biliary obstruction is unusual, which we had seen in this patient. And even in malignant SPEN, there is no effective chemotherapy protocol available in literature, which is known to reduce the size of these tumors to make them resectable. To keep these tumors stable, there are various protocols, various chemotherapy regimes which are available, and those tumors which are progesterone positive, tamoxifen for a long time is known to keep it stable, but there is no report in the literature which suggests that it can downstage the disease. So for SPEN, even for malignant SPEN, there is, as I said, there is no new adjuvant and adjuvant treatment prescribed in the literature, and no response of liver metastasis to chemotherapy in the literature. Just to complete this discussion on malignant SPEN, 2019 WHO gave a criteria of high-grade malignant SPEN, which is actually now solid pseudopapillary carcinoma, not SPEN. So the important criteria for diagnosis is the tumor cells are uniformly showing high levels of ATP and extensive mitotic figures. If there is presence of angioinvasion, perineural invasion, and deep invasion of somatic pancreatic tissue, so then this malignant SPEN is diagnosed on histology. So the next I am considering is neuroendocrine tumor. When you are considering neuroendocrine tumor in a 25-year-old female, you have to consider that in young neuroendocrine tumors, most of these patients are actually accompanied by some kind of syndrome, which can be either multiple endocrine neoplasia, von Hippel-Lindau, neurofibromatosis, and none of this is in our patient. However, pancreatic neuroendocrine tumor can be non-functional, and 1/3 of these patients actually are in the head of the pancreas. If we look at non-functional neuroendocrine tumors of the pancreas, the median age is generally elderly, as I said, 57 years, but then the reports even in younger patients are known. The non-functional neuroendocrine tumors can present with pain abdomen and large mass without jaundice, as was initially the case in our patient as well. And the CT findings which we had seen are also seen typically in neuroendocrine tumor, except that in a small neuroendocrine tumor, you will find early arterial enhancement, which may probably become heterogeneous when the tumor is large, as in our case. And large tumors of neuroendocrine nature or origin can have a mass effect on the pancreatic duct, which we had seen in this patient as well. Coming to the important aspect of neoadjuvant treatment, which this patient received, in neuroendocrine tumors which are non-functional, if they are initially locally advanced, nowadays there are neoadjuvant treatment which is being increasingly used, including the use of PRRT or radionuclide therapy, and that is leading to shrinkage and making these tumors regress and resectable. However, in adjuvant setting, there is no definite evidence, but still, if there are pathological markers of perineural invasion, lymphovascular embolization, or lymph nodes which are positive, then there is a setting for adjuvant treatment, which this patient also has received. So as I said, the odd points are the median age, which is higher, but that I said it can be explained by number of reports in younger patients. Higher proportion, which is slightly more, so I would dismiss this. But we do not have any chromogranin A levels in the whole scenario. So that makes me little doubtful. And also we do not have gallium dotatate, which is the workhorse for imaging in these neuroendocrine tumors. So when we talk of neuroendocrine tumor, the differentiation, the grading of neuroendocrine tumor is basically on the differentiation of the tumor as well as on the proliferative index. So in my case, I am looking at neuroendocrine tumor grade 3 because grade 1 and grade 2 tumors will not require chemotherapy, though even if they reach large size, they generally would not require chemotherapy as most of them are somatostatin receptor positive and would receive treatment according to that. But this patient received chemotherapy, neoadjuvant chemotherapy. So I am keeping neuroendocrine tumor grade 3 as one of the possibility. So I'll go in little more detail about this neuroendocrine tumor grade 3. Neuroendocrine tumor grade 3 can be both malignant and benign. And as I said, this if we look at well differentiated and poorly differentiated. The poorly differentiated neuroendocrine tumor grade 3 is actually also called as neuroendocrine carcinoma, which may be small cell or large cell type. It has generally been seen that if we look at the proliferative index and if it is well differentiated neuroendocrine tumor, the proliferative index seldom exceeds 55%. So well differentiated histology in all the group of PNET G3 is only in 18%, which I think is where our patient probably fits. The primary tumor is in the pancreas, which is in 2/3 of these patients. Positive FDG PET is also seen in 75% of the neuroendocrine tumors grade 3 compared to 88%. But the major problem here is that most neuroendocrine tumor grade 3, which means even if they are well differentiated, they will have somatostatin receptor positive. So if it is NET even grade 3, which means proliferation is more than 20, you would subject this patient both to FDG and PET. But our patient only has PET, so that is a little, a pointer which is going against my diagnosis of PNET G3. Chemotherapy is the first choice of treatment of G3 and NET because these are highly proliferative and aggressive tumors. And what we have seen is that these patients, they generally respond to capecitabine, temozolomide chemotherapy rather than to etoposide or platinum, which is given for malignant or neuroendocrine carcinoma. This patient had 18 cycles in neoadjuvant setting. This can probably be explained by initial treatment, initial response to Captum, and then oral capecitabine, which could have been continued after the response was seen in the initial phase. Coming to the next possibility, which I am keeping lower down, is acinar cell carcinoma. Head of pancreas is the commonest site for acinar cell carcinoma. Understand they comprise 1% of the pancreatic cancers. Only 10 to 50% are reported to be resectable, as our patient also was unresectable. Abdominal pain is a major complaint. Evidence of pancreatitis, as we had seen in this patient, is seen in acinar cell carcinoma. CT and MR images show large heterogeneous masses which contain both solid and cystic component, seen in our patient as well. Surgical resection is the treatment choice. However, they respond to chemotherapy as well as to radiotherapy, and if you combine, they can actually achieve much better survival compared to the adenocarcinoma. The points against acinar cell carcinoma in this index case are, infrequently seen acinar cell carcinoma in females, and age is generally more than 60 years, and they present with weight loss like adenocarcinoma. This patient did not have weight loss for almost 6 months prior and 8 months after the presentation, for 14 months. And then she developed jaundice and started having weight loss. So this is another pointer against acinar cell carcinoma. Lipase hypersecretion syndrome is seen in 10 to 15% of these patients, which is a kind of a paraneoplastic syndrome. And these patients will be picked up on staining with antibodies to antitrypsin, chymotrypsin. Important to know that, another point why I put it here on the side of against this is that they respond, if the kind of response we have seen in this tumor, this response in acinar cell carcinoma will be seen in FOLFIRINOX and not in gemcitabine based therapy. So if we are giving FOLFIRINOX, it is unlikely that this patient would have been receiving 18 cycles. So probably these are the points which are against, and I'm keeping it very low on the card. This is a tumor which is in the tail of the pancreas with a large lesion in the liver, and that again is showing solid cystic component. This is a typical of metastatic acinar cell carcinoma. What about adult pancreatoblastoma? We know pancreatoblastoma is generally a disease of infancy, or median age is generally 4 years. But there is another entity called as adult pancreatoblastoma. It originates from fetal pancreatic stem cells. The mean age is 45 years, which ranges from 22 to 65 years, in which range our patient also falls. And 50% arise in head of pancreas, as in our case, and well encapsulated, as was our patient as well. So they again present with abdominal pain and palpable abdominal mass, but because of the aggressiveness, these tumors are again unresectable as was our patient, and liver metastases are common. If we consider the metastases or the cystic lesions in our patient were also metastatic, and they are seen in adult pancreatoblastoma also. The response rate of pancreatoblastoma to chemotherapy is 70%, and generally with cisplatin and doxorubicin. But please understand that this combination is very difficult to tolerate for 18 cycles. And if these patients are incompletely resected, post-operative radiotherapy has a role. But again, the points strongly against pancreatoblastoma or male preponderance, frequency which is in the first decade. Importantly, we do not have elevated AFP levels which are hallmark of pancreatoblastoma. And CCT which shows a solid lesion with some cystic component, and survival is only 18 months. However, in our patient, we have seen a good course. And this is what I said, there is some stippled calcification, which you can also see in a non-enhanced CT scan in these patients. What about pancreatic ductal adenocarcinoma? Head of pancreas, without discussing pancreatic ductal adenocarcinoma, no discussion can be complete. But in a young female, it is unlikely. But more importantly, the patient who presents with a large mass without jaundice, that is unheard of in ductal adenocarcinoma, which is very unforgiving. And also equally important, in ductal adenocarcinoma, no loss of weight and appetite, a large tumor, and no rise in CA99 levels. Large solid and cystic mass, and patient relatively well preserved. Only positive thing is double duct sign, which gives us a clue to ductal adenocarcinoma. But then all other signs are not in favor. As I said, well preserved patient even after 18 cycles of chemotherapy, and this patient has received adjuvant chemotherapy and doing well. So all these things are very, very unusual in ductal adenocarcinoma. So there are some rare conditions which were listed initially, and I'll just complete the list here. I'm not seriously considering these. Ewing sarcoma is an aggressive malignancy which actually affects bones rather than pancreas. Less than 30 case reports are there in the literature. It can present with abdominal pain, but generally has a progressive jaundice, which was not in this patient. The lesion can be hypo or isoattenuating to the normal pancreas, and T2-weighted images also show the similar findings. It usually features ill-defined borders and heterogeneous post-contrast enhancement. These tumors are generally hypermetabolic, and surgery plus standard chemotherapy regime can lead to some improvement in the survival in these patients. However, these patients have very high recurrence and metastasis rate, which is not the case in our patient who has received neoadjuvant, adjuvant, and also is doing well in follow-up. So I'm not considering this. The other thing is Kaposiform hemangioendothelioma, which is commonly manifested during infancy or early childhood, and only less than 10 pediatric cases. I would not have discussed these cases unless it was if it was not a CPC. They can cause obstructive jaundice and cause progressive abdominal distension. They can cause consumptive coagulopathy. CT-MRI reveal infiltrative soft tissue lesion, which is not in our case, which is not the case in this patient. And complete resection because of this infiltrative nature may not be possible in caposiform hemangioendothelioma. And role of adjuvant chemotherapy can be considered. I am not considering this because of the so many things which are against this, and especially even in pediatric age group, which is the commonest age group, less than 10 cases are reported. So, ladies and gentlemen, my first diagnosis based on the database is grade 3 neuroendocrine well-differentiated tumor. It is less likely we are dealing with neuroendocrine carcinoma. My second diagnosis is malignant solid pseudopapillary neoplasm. And lastly, I would give some importance to SNL cell carcinoma. Thank you.
I invite Dr. Shaneem from nuclear medicine on his comments on the PET scans. Do we have anybody from radiology?
Thank you, Dr. Actually, हमें भी पता लगा है कि diagnosis there was a mass in the pancreatic head region, which was not fitting into the pancreatic CA, which is the common site for the pancreas. And even, I don't know, we forgot to give the information regarding the gallium glutamate scan, which was done here. Gallium glutamate scan was done. I don't know, we missed that. Yes, we missed actually. I don't know why we were not able to. Yes, so that was done and that was negative. And that was a negative. That's the important information actually. Yes, that was a negative. So your first differential will be, I think, out in this case. So that was a negative case. So at the offset, in the start, we were not knowing what is the diagnosis. So we know there is a pancreatic mass at that region, but we have given the definition of pancreatic primary, and then that was the only option we had that point of time because there was no other lesion metastasis. तो हमें तो ये बताया भी गया कि सर को डायग्नोसिस नहीं बताना, वैसे अगर आप तो हो ही है तो बता सकते हैं. तो एनीवे, तो कुछ आई थिंक और कुछ ऐड करने के लिए नहीं है पेट सिटी में. Liver lesion was slightly positive on activity PET. They were solid component. Yeah, they were solid component, but they were showing some optic. They were not. They were metastatic. Yes.
Any more differential diagnosis from the house? I would request Dr. Saurabh to comment. Into tumors and I would invite Dr. Saurabh about the provisional diagnosis which they kept before operating the patient. So before planning the surgery, so what was your working diagnosis?
So actually this patient initially presented with the complaints of acute pancreatitis. So I only advise that you can go ahead and do a cholecystectomy, which can be done outside also. But then she presented 3 months later with jaundice, and we have done multiple biopsies, FNACs, and our differential was also a carcinoma versus an NET, even initially also. And but I won't right now reveal the diagnosis, but the mass per se was unresectable at the outset itself. And there was some suspicion of liver metastasis also. But unfortunately, they were not positive. But still, because it was locally unresectable, we went ahead with a SEMS placement. And then actually after 12 cycles of chemotherapy, we had given an option of a vascular resection to the patient. But because the patient, and discussed with oncologist also, But because the tumor was actually showing regression with subsequent chemotherapy, the patient was of the opinion that I can go ahead with further chemotherapy, and the medical oncologist said, okay, we'll give 6 more cycles. And after 6 cycles, when we did a PET scan, actually there was hardly any uptake close to the vessels. There was still a soft tissue lesion. We discussed it multiple times with the radiologist, and there was a soft tissue lesion around the vessels, especially the SMA. So that's why the surgery was itself planned with the help of CTVS in the CTVS OT itself. And so we went ahead with surgery with a plan of actually a portal vein resection. But intraoperatively, we found out that the soft tissue, we did not have any distal margin to actually go ahead with a SMB resection. So we still were able to achieve a Whipple's pancreatiduodenectomy. The problem was that we were suspecting that there is a possibility that there could be an R1 resection at this point in time. But the only thing was, because the tumor at the time when we actually did surgery had regressed only about 2 into 2 centimeters, and the uptake was actually away from the vessels. So we thought probably we might achieve an R0 resection. And the thing is that post-operatively, whatever the diagnosis came, the patient is actually doing pretty well. She received adjuvant as per the final diagnosis, and that probably ma'am will discuss. And she's doing pretty well. This is 1 year down the line, and she's doing okay. Yeah, at that time we had a diagnosis that it's a PDAC, and it has responded to the neoadjuvant that we have given, and she was doing pretty well, PCOG1, everything. So this, we have to give a chance that at least if we can do away with the portal vein resection at the time of surgery, it will be beneficial for the patient. So that was our initial diagnosis at that time. Yes, sir. It was known. That time it was known. We had some differentials initially, but at the time when neoadjuvant started, we had a differential, and we also had a suspicion of metastasis, which was eventually ruled out. So we had a locally advanced unresectable tumor.
Any other differentials from the audience which sir has not discussed maybe?
I'm not considered system of the country because predominantly solid component is 50 kg. So I did not have any 60 kg.
So let's go ahead and see what the pathology unveils. So this was the first biopsy from this patient. So it was an endoscopic biopsy from the ampulla, which was looking bulky and ulcerated. And here we can see that these are the duodenal mucosal fragments. So here we have the villi. And so at the low pile itself, it appears abnormal. So it is not looking within normal or non-specific like. So at the higher par, we can see that there is a destructive process happening here. So this is the muscularis mucosae. So we have got some portion of the submucosa also in the biopsy. And if we look at the epithelium here, so the epithelium is not showing dysplasia. However, there is an expansion of the lamina propria and the submucosa by some atypical cells. So this is the lower part. So the cells appear very small at this. And the higher part, so these are diffusely infiltrating in between the crypts and also into the submucosa. So it itself actually tells that this is a malignant process. And the cells, they are growing in a single cell fashion, as actually we see in the gastric carcinomas. So again, in between the crypts, you can see all these blue kind of cells. Here they are growing in a solid sheet-like fashion. However, see the crypts and the epithelium is not showing a typical atypia, which we see in the adenocarcinoma, which is the most encountered entity at this site. So this is the higher part. If we look at the cells, so they don't have any particular architectural pattern and they have a high NC ratio. So these are hyperchromatic nuclei, which are actually displaying variation in the sizes and the contours of the nuclei. We can't see the nuclei here. There is no gland formation. There is no mucin. So basically it is looking a bad or poorly differentiated or an undifferentiated kind of tumor. So we did a pan-cytokeratin, which was diffusely and strongly positive in these cells. And then, yes, so we had a suspicion of neuroendocrine carcinoma. So we did a neuroendocrine panel. So normally we do 2 neuroendocrine markers in the first go, which is chromogranin and synaptophysin. So once they were negative, we went with the second panel, which is INSM1 and CD56. So all the 4 neuroendocrine markers, they were negative. For the possibility of the SPEN, a beta catenin was done, so that was also negative. However, a Ki67 was 40%. So that was again telling us that it is a poorly differentiated malignant tumor. So as the CK was diffusely positive, so we went ahead with the possibility of a poorly differentiated carcinoma. So based upon this diagnosis, so yes, patient underwent a neoadjuvant chemotherapy for carcinoma pancreas. So yes, with the cycles, the size of the lesion decreased and subsequently the patient was able to undergo a resection. So that's the resection specimen. So here we can see, so yes, there were dense adhesions, so it was difficult resection and finally, but it appeared R0. And this is the ampullary site where the stenting was done. And here we can see in the pancreas, we have this solid gray white firm area. So it was like 3 into 2 centimeters and it was quite fibrotic looking on the gross itself. Now, so that's the microscopy. So again, the section showed a tumor. So it had this diffusely infiltrative pattern if you see. So this is the 4x part and the tumor is infiltrating in between the vessels and the ducts and everything. So normal parenchyma, and it doesn't have any particular architectural pattern. So if you look at the pancreas, so yes, out of 190, more than 90% will see adenocarcinomas, which can be poorly differentiated, but we don't have any gland here, no mucin, nothing. So that's a poorly differentiated looking tumor. Now these are the pancreatic acini. So tumor is diffusely infiltrating into every structure encountered. Now this is the vessel. Here we can see this is a duct which is massively dilated. Here we have a lot of fibrosis. So these are all chronic pancreatitis-like changes in the adjacent pancreas. Now this is the muscle of the duodenum. Again, it is infiltrated by the tumor. The tumor is going into the submucosa and this is the mucosa. So the tumor was reaching till the mucosa of the ampullary region. So that's why we got the tumor in the upper GI endoscopic biopsy. Now, in some areas, we could see this ill-defined rosette-like arrangement of the tumor cells around the vessels. And though the tumor was growing around these nerves and the vessels, it was not actually infiltrating the wall of these. Now that's the higher part. If we look at the tumor cells, so they are small, but they have this pale vacuolated scanned cytoplasm and the chromatin is coarse and there are tiny nucleoli at places. So there was some mitosis and apoptosis. And then we had a lot of changes due to therapy. So this is abundant fibrosis, which we could see in the tumor. And all the lymph nodes, they were reactive. So they did not have any metastasis. So again, we did our first panel. So CK was brightly positive, as was on the biopsy. The neuroendocrine markers again turned out to be negative. So yes, the first differential for us was also of a poorly differentiated neuroendocrine neoplasm. So that's why we again repeated the same markers. Desmin was also nearly negative. So it was looking like a maze to us. So we thought what to do. So let's go back to the morphology and hunt for the clues. So if this morphology I would see at some other site, so that becomes easy for me. But since I was seeing it in pancreas, so it becomes difficult for me. So if we think that this is in the bone? Yes, so we did some second panel. So these are two markers. Any guesses from the residents? So that's a CD99 or the MIC2 and that's a NKX 2.2. So both of them, they were nicely positive. So that's a diffuse membranous stain for CD99 and a nice nuclear expression for NKX 2.2. So we thought that are we looking at an extraskeletal Ewing sarcoma? So then we started working up it as a small round cell tumor and ruling out other differentials. So we did a SOX10, it ruled out a clear cell sarcoma, a melanotic melanoma and a neural tumor. A negative TLE excluded a atypical looking synovial sarcoma. Then a DSRCT, desmoplastic small round cell tumor was excluded with a negative WT1 androgen receptor and calretinine. So though these all other small round were not in the differential, but we still wanted this time to be very sure for the diagnosis. And then we confirmed this diagnosis by doing a FISH on the formalin fixed paraffin embedded tumor section. And so this was done using a break apart probe. So normally we see yellow signals, which is like a few signals in the normal cells. Here we can see like 2 red, green. So these are separate. So more than 50% of the tumor cells, they showed these separate red and green signals, which actually confirmed the EWSR1 rearrangement. We repeated the same IHC on the biopsy, which we had reported as PDCA. So MIG2 and NKX 2.2, they were nicely positive on that. So actually a CK misled us to a diagnosis of a carcinoma. So the final diagnosis was a Ewing sarcoma of pancreas. Now let's see some facts about this diagnosis. So the nomenclature has been continuously changing. So now Ewing sarcoma family of tumor, it includes the classical Ewing sarcoma of the bone, the extraskeletal Ewing sarcoma, and these entities Askin and the primitive neuroectodermal. So these are now extinct. So they have not to be followed. So if there is an undifferentiated small round cell sarcoma, which, so they have this similar histology and IHC, the Ewing family, and they have to have this gene fusion, which is involving one member of the FET family and another member of the ETS transcription factor. This entity was first described by an American pathologist, James Ewing, and the cell of origin is a mesenchymal stem cell. So these are very common in the bones. So second most common after osteosarcoma, and the long bones and the pelvis and the ribs are commonly affected. And 80% of the patients are below 20 years. So they are uncommon in very less age and older than 30 years. Now in the soft tissue, they are, yes, uncommon. So see, 12% are extraskeletal, and in the solid organs, they are much rarer. So this is classically required to make a diagnosis of Ewing sarcoma or the Ewing's family of tumor. And see, out of all the rearrangements or the fusions, the most common is this EWSR1 Fly1, which is seen in more than 85% of the cases. Then once the fusion product is actually created, so that subsequently activates the RNA polymerase and then the transcription and the cell proliferation. Now, how the nomenclature has changed over years. So initially, see, the Ewing sarcoma was discovered. Then subsequently, the new entities, atypical, extraskeletal, including the Askin and the primitive neuroectodermal, they were actually discovered, and these were considered as separate entities. But as the advances took place, so the gene rearrangement and the fusion studies were done on these tumors. So it was identified that all of these, they are related. So if we have PET and ETS family fusion, so you will call it a Ewing sarcoma. Then it can be typical morphology or it can be atypical. And if either the non-FET or the non-ETS is there, so those tumors are Ewing's like sarcoma. So now even they have been further subdivided because it is believed that they are not same as the Ewing sarcoma, but they just look like Ewing's. So these can have this, they can be BCOR rearranged and the CIC mutated. So these different translocations, they actually classify these Ewing-like sarcomas into further many entities, which are quite uncommon. So on histology to us, so if a tumor has a classical small round cell morphology and a nice MIG2 and NKX with a EWSR1 rearrangement, so that becomes easy. But sometimes it doesn't have that morphology and it may be atypical. So if it is atypical morphology, but still the IHC works and there is a rearrangement, so then it can be labeled as a round cell sarcoma with EWSR1 rearrangement of the fusion. And then the fusion partner has to be seen. And the Ewing's like tumors, so they don't have a typical morphology and they have this patchy and different IHC pattern. And then subsequently they have to be actually typed based upon the fusion partner which is involved. And these actually behave differently as compared to the classical Ewing's. Now, other than Ewing's, the other small round cell tumors at time comes into differential, so which have to be excluded on case-to-case basis depending upon the morphology encountered. Now, metastasis is the most important prognostic factor. So the patients with localized disease, they have a much better survival. And the mainstay of the treatment is a neoadjuvant therapy and surgery as in our patient. And this will be discussed in the end by the medical oncologist. So what was the pitfall in our case? So we had a nice CK. So yes, if this study highlights that in 40% of the cases, cytokeratin can be expressed and that can be diffused. Now, if we talk about the pancreatic Ewing, so there are like approximately 30 cases reported in the literature and most are a single case. And this is the only case series which I found. So this is from two centers, Johns Hopkins and the Texas Center. And they studied these 13 cases, out of which 9 were males and 4 were females, and the median age was 27. And the primary inclusion criteria was that the mass has to be primary pancreatic on the radiology gross or the intraoperative findings. So yes, it is not that uncommon, so we can encounter that. So now if they are advanced, like in this case, 18 years female with adrenal metastasis, retroperitoneal lymph nodes with a pleural effusion, she expired soon. So the stage is actually guiding the behavior and the prognosis of the patient. Then this is another example. So this again young female, a large pancreatic mass, she had sacral and left supraclavicular lymph node mets. So then only the chemotherapy can be given. So sometimes they are that bad. However, if they are localized, like in this case, 16-year male, 8 centimeter mass, so he is disease free for 4 years. So if it is localized, it is resectable, it is good. Another case, a 4 years female child with a 5 centimeter mass, metastatic workup was negative. So PET scan actually plays a very important role to stage the disease and guide the treatment. Then other than primary, yes, rarely you can have metastasis also into the pancreas. Though pancreas is a very resistant site to metastasis and most of the mets you encounter in pancreas are from RCC. But still you can have sometimes tumors which are very uncommon and they metastasize to pancreas. Now that is one of our case. So in last 3 years, we have 3 cases. Other than the present case, we have 2 other. This was a 1-year female child, and this is a cystic pancreatic mass which was resected. So the clinical and the radiological differentials and even the gross differentials we kept as a solid pseudopapillary and the neuroendocrine tumor. And microscopically see what it turned out to be. So that these are the sections from cystic areas. And this was a small round cell tumor. So it was positive for again MYC2 and NKX, and it had a EWSR1 rearrangement. So that was a 1-year female child. Then this is a recent case, 2024. So this is a EUSFNB, 35-year female, and the differentials were adeno, again neuroendocrine lymphoma in the gist. So we can see a lot of blood and tiny fragments of the tumor. So once we encounter one uncommon case, we are much wiser next time. So a small tissue sample, but we clinched the diagnosis. So a small round cell tumor with a MYC2 NKX positive, EWSR rearranged. So that's a diagnosis which has been clinched on a EUSFNB. So to conclude the case, these are my acknowledgements and the quote that medicine is a science of uncertainty and an art of probability. I would invite comments from the audience. Any questions regarding the pathology or the ISC, the diagnosis? Otherwise, I would call the treating clinician. So I would call Dr. Sameer, the medical oncologist, and the surgeons to tell about that, what therapy was given after that, and how is the patient doing now.
Hi everyone. And see, after the diagnosis of Ewing sarcoma was out, there were 2 dilemmas. One, the diagnosis changed almost completely. Second, the unit in the medical oncologist changed. So the patient was transferred to us. And this being a very atypical age for Ewing sarcoma, I mean, 80% happen less than 20 years. Secondly, atypical site. It's not bony site, extraskeletal. I mean, highly unusual to have Ewing sarcoma in pancreas. And third is exceptional response to FOLFIRINOX, which is actually not the drug for Ewing sarcoma, but irinotecan might have some activity in Ewing sarcoma. So these challenges we were like facing post surgery. We got scan done and there was a very small lesion that could be residual and that could be post surgical fibrosis. But then to be on safer side, and of course in Ewing sarcoma, if it is extremity, you can operate it altogether, give radiation easily, have margins. But here margins, as I discussed Dr. Saurabh also, and we were discussing Dr. Shamim also, they were seeming a bit doubtful. So we started Ewing sarcoma protocol. So far, she didn't receive doxorubicin and ifosfamide based protocol. So we gave ifosfamide, etoposide, and VEC protocol. But she, having received 18 cycles of FOLFIRINOX, the tolerance was dismal. So after 7-8 cycles, we have to abandon it. And we also gave her radiotherapy. It was 25 fractions, 50 gray of radiotherapy. Again, the limit for abdominal is almost 50 gray, because then duodenal will get fired. So far, I mean, post-treatment, one scan has been done and she is doing absolutely fine. And the last imaging was no disease. There were no metastases. They were all cysts. Yeah. And in fact, translocation was also done.
this patient, when the FNOB diagnosis you must poorly differentiate. What kind of use of Parkinson's? Because you are considering, I have to look back, the similar case which comes to us, that is how we were analyzing. The first diagnosis still remains neuroendocrine. And if it is poorly differentiated, you take normal, poorly differentiated, and then you plan treatment. Instead of looking at the clinical scenario and the poorly differentiation, probably etoposide and platinum would have been the first line of treatment considering this. We gave phosphate plus. What was the reason to give phosphate? What was the idea of it?
So I think the treating unit was different. It was GI unit at that point of time, but they thought it to be pancreatic adenocarcinoma. Their working diagnosis at that time, with the limitation of tissue, as Saurabh said, multiple time biopsy was done. Pancreatic adenocarcinoma.
Young patient initially itself started like at the very outset we started. But it worked. We had already ruled out because initially there was a suspicion of NAT. High grade NAT was kept in the initial evidence. If we see the first probability in the initial, it was kept as high grade NAT. That time actually we had suspected we could operate even with metastasis it's an NAT. But the final biopsy came out to be adenocarcinoma, so it was pancreatic.
I haven't shown the cytology slides, I couldn't retrieve. But on a cytology, we had given a differential of neuroendocrine neoplasm and spin. So because not a lot of mitosis or apoptosis was not very apparent, so we had a morphology of small cells, but then the mitosis was not that. And then we could not do a lot of markers on cytology. So then we got a biopsy. And then we were very sure that we are looking at a non-neuroendocrine thing because we did 4 markers and all 4 were negative. So that, and CK was very diffuse.
The other message of this case is that we get too much mild into gender and age. This events are common defined both. More common in males. The age group is also in the the first diagnosis that because of the typical age group and the gender.
But most of the cases which I found in the literature, like these 30 cases, most of them they are in females, surprisingly. Though in the bones it is more common in the males, but somehow all the pancreatic I was finding mainly in the females.
16 patients. The thing is, one more. She had that initial hypotension. That time actually it was, but we were led astray at that time. Because the hypotension at the outset it still remained at the same point. The origin is still remains at the same point. I actually pointed it out in one of the gastroenterology conferences so that it can be actually a first presentation of a pancreatic.
We should actually visit because I think we got misled by the very pancreatic. We should actually look at the hypothesis.
The US which actually revealed because the biopsy was also done in that. Ductal epithelium with some blood. There was no ATP cells in the first few years.
Done here.
In the first few years.
Was it done here?
No,
That time actually it was the same.
This I don't read too much about it because so this is probably chemotherapy is still warranted if we have a question is what do we do if they make a diagnosis preoperatively of AIIMS? Do we go ahead and do surgery straight or give a chemotherapy first in neoadjuvant and then operate and achieve a longer survival?
But if pathology was, known,
if on biopsy we tell that it is eating, so how would you?
yeah, so the
Borderline of the blood vessels which can be tackled. What should be the plan in these patients?
so for wing sarcoma, the protocol is well laid. We have to give neoadjuvant chemotherapy because this is micrometastatic disease at the outset. And you give 6 cycles, then definitive treatment, including surgery if possible, and radiation therapy if the site is remote. Yes, sir.
Number 2, CK1 positive, number 3, problem is here, so all 3, everything wrong, but patient treatment.
That's a good thing.
Yeah. So far, Ewing sarcoma, you take any translocation or any IHC, they are not predictive of any response. They are neither prognostic nor predictive. There is ample data to say as that. In fact, once I got that CK report, I went to her and we saw the morphology, whether it was not desmoplastic small onset tumor, because they get me, of course, 20% Ewing sarcoma have this CK positivity, but then desmoplastic small onset tumor might have CK positivity. Oh, CK.
The other 2 cases are cases. No, so we have not done. So we became much wiser after that.
And how are you treating the fresh?
1 year the chemotherapy was given. It was Dr. Sandeep Agarwal's case, if you remember. So, and this is the most recent which we have given. So this patient is also receiving chemotherapy. So I think, yeah, on small samples also we can do dry clinch. No, it's a NKX. So isme we did not do a CK. In this case also I did neuroendocrine markers and I did actually lymphoma markers also. So we did lymphoma panel and the neuroendocrine panel and then this. So, but this was the 3rd case, so we had a high suspicion that it may turn out to be Ewing's. So yes, sir, the series I have shown, so in 43 cases they have done, and out of that 40%, I think it is, yeah, it is frequently expressed. I think Adesh may tell her, so CK is frequently expressed, no? Yeah. Thank you, everyone.